So I'd like to welcome you all again to our next edition of the Pediatric Spine Academy India webinar. And this time we have our very own Dr. Jwalant Mehta, who will be taking us through the topic of pediatric spondylolysis, one of the most important topic in pediatric spine as sports injuries increase and as kids come to us. This is one of the things that we are commonly seeing. So as you all know, that Dr. Jwalant Mehta is a consultant spine surgeon in Birmingham at the Royal Orthopaedic Hospital and Birmingham Children's Hospital. He serves as a pre-committee member of the SRS, and he is the past chair of the fellowship committee at the SRS. He has published significant peer-reviewed articles in the journal, and he is a reviewer at one of the top journals across the world, like the European Spine, the Spine Deformity, and Global Spine, and many more. So over to Dr. Mehta to start with the topic of pediatric spondylolysis. Over to you, Dr. Mehta.
Well, thank you for giving me the opportunity of discussing this very important topic, pediatric spondylolysis. These are my disclosures, but not relevant to this talk. So the outline of the talk, we'll talk about the incidence, etiology, pathogenesis. We'll look at the sports angle, treatment and treatment options and outcomes. And the sports angle is really important because we treat sportsmen in the same spirit as we treat children or adolescents. And it's more a question of getting people back to their activities rather than doing any damage limiting fusions. So we'll come through, we'll discuss that in some detail. So incidence, it's about 6% in general population based on X-rays. But if you were to see asymptomatic cohort based on CT scans, it's a little more. So it's much more common than one imagines. At birth, 0%. By about 6 years, it's 4%. And then it gradually increases to about 6% by 14 years. And that stays on in the adult age based on X-ray findings in asymptomatic patients. So the first peak that we see is 5 to 7 years, and the second peak is in teens. L5 is the commonest level during the growth spurt, and L4 is the commonest that causes symptoms. So this is typically the lesion that we see in spondylolysis. This is the intraoperative picture of a patient that has bilateral pars defects. And what we see is this movement of the posterior arch that some people call the rattler because it looks like the rattle that kids use. So in terms of pathogenesis, it can be unilateral or bilateral, and it can be seen at any level from the subaxial spine down, although L5 is the commonest. It is common in adolescents in certain sports, and there is a certain complex that I call stress spectrum continuum. It's really important to understand this because many of the patients will feature somewhere along this spectrum, and that will help us identify how we treat them. So this spectrum is actually a stress response. It starts up as a stress reaction where there's no fracture. Then you have an incomplete fracture, complete fracture, and then what we know as a chronic defect or a non-union, as we know in orthopedic language. These can be at the same level. You can have it unilaterally or bilaterally. You can have it at different levels. You can have active and inactive or active and chronic at different levels at the same time. So it doesn't matter. There's no pattern to it, but you can have a variety of different combinations. The predisposing factors or the risk factors, one of them is mechanical overuse. Then we look at sagittal spinal realignment. There are genetic factors and there are some systemic factors. So if you look at the pathoanatomy of the posterior arch, it's a very unique part of the anatomy to the lumbar spine, and hence it's commonest here. It's more common in the growing skeleton. There is an element of genetic predispositions, and it is quite common in extreme activities such as in certain sports. And what actually happens here is there's a fatigue injury. There's accumulation and propagation of micro damage at a rate that is greater than the repair. So the Japanese group have studied this in some detail, and what they've worked out is that the fracture actually starts at the lower edge of the pars and then gradually moves up. And this is a pattern that we've seen even in clinical studies. So this is something that is now well understood. In terms of mechanical factors, anything that causes hyperextension, axial loading, axial rotations, torsions, and repetitive action, the repetitive part is really important, is bound to cause this kind of a lesion. So in this situation, what we have is you have repetitive stress, maladaptive remodeling, and that leads to the stress response spectrum that we saw earlier. So the extreme sports, anything that involves impact, hyperextension, twisting, high arc of action, and particularly throwing sports, and some of the examples that I've showed you. These are some of the at-risk sports, and we'll go through this in some detail, but the specific ones that I'd like to focus on are throwing sports, mainly cricket. So if you look at incidents by sport side, it's very common in American football, in the linemen, wrestlers, rowing, baseball, even weightlifting, swimming, rhythmic gymnastics, but it's particularly very common in fast bowlers in cricket. So in certain throwing sports, you have an asymmetric loading pattern. So what happens is you have a greater stress on the contralateral bars to the bowling arm. And this particular type of injury accounts for 3 to 12% of all cricketing injuries. And this is particularly so in certain situations where you have a low bone density, increase in the workload, and it's linked to age and skeletal maturity or immaturity. So this is a group from Loughborough that have done a lot of research on cricket fast bowling technique and lumbar bone stress injury. And they've actually worked out a lot of different aspects of the bowling action that can lead to stress responses at different time points in different parts of the spine. One of the things that has been worked out is that the bone mineral density is asymmetric in elite cricket fast bowlers. And what they've said is that it's usually on the non-dominant side, it tends to be less. And if it is less, then it can lead to a stress fracture. Similar pattern has been seen in female cricketers. And as we know, there's a World Cup going on in India right now, and we have the first semi-final being played today as we speak. And this study from the same group looks at elite female cricketers, and we look at fast bowlers, spinners, and batters. And what they show is that all cricket positions, all different types of subgroups show high bone mineral density at all measured sites. Especially in the lumbar spine of fast bowlers, it's asymmetric and it's greater on the contralateral side, particularly at L4, and it's possibly linked to the asymmetric loading in the fast bowling realm of activity. Now, this is a study that was done by the group looking at specific bone mineral density in patients that have stress fractures. So IL is the ipsilateral group and CL is the contralateral. And if you see that the contralateral, the bone density is much higher, especially in the uninjured as compared to the injured group. And this is really important to understand this differentiation between the contralateral ipsilateral side and in the injured and uninjured patients. The other thing that we hear a lot about, especially in the context of cricket players these days, is workload and seasonal variations. And this is something that has been seen really well. And especially in my practice, we see a lot of similar injuries, even in young adolescents and school kids in certain seasons, which is what we call the cricketing season here in England. And they've also worked out that 0.13 per 10,000 balls bowled. That's the load. That's an incidence that you'll find. And if you bowl over 234 deliveries in a 7-day period, over 39 which is about 39 overs, that's definitely a risk factor. So we have a definite causal association between workload and seasonal variation, and hence workload guidelines have been recommended. And this is a study that shows the same thing, and that the lumbar bone stress injuries is much higher in certain young cricketers, and it gets more as they go and play in senior levels, in academy, and then leading on to professional levels. The other thing we need to look at beyond cricket is the sagittal spinal pelvic alignment. So as we know that the bipedal stance that we have evolved into is very evolutionary, and we don't see spondylolysis in quadrupeds. The lumbar lordosis that we have developed is to allow the center of gravity to fall posteriorly so that we can have a head high up while we are walking. And this has led on to two different types of mechanisms for creation of this spondylolysis, which is the shear loading or the nutcracker type. And added to that, we have the cyclic loading. So the shear loading is where you have high lordosis, high sacral slope, and high pelvic incidence, whereas a nutcracker is when you have low lordosis, low sacral slope, and low pelvic incidence. And this is an image on the right-hand side that just is an aid memoir to what pelvic incidence is, pelvic tilt is, and the sacral slope. We've also looked at something called a sagittal pars inclination angle, and this is still a bit of work in progress in our unit. We've looked at CT scans of 255 pars in 37 patients, comparing the ones with the intact pars to the ones with pars defect, and we've identified this one angle which is definitely higher in certain patients that have a higher risk factor for developing a pars fracture. Then there's a genetic predisposition. It's common in first degree relatives, commoner in males, commoner in certain groups like Inuits. We're not allowed to call them Eskimos these days. They're called Inuits. And it's as high as 60% in patients who have osteogenesis imperfecta, osteopetrosis, etc. Marfan syndrome, it can be pretty high. The natural history, most heal spontaneously with or without treatment. And the healing can either be solid or fibrous. Even a fibrous union could either be progressive or stable. But what's important is if they don't heal, they can disable the facets from contributing to shear loads, making the discs more vulnerable. Then the discs secondarily wear out, and in 5 to 10%, you can lead to spondylolisthesis. Clinically, 90% of the patients are asymptomatic. But if you have recurrent pain with certain activities, especially during the adolescent growth spurt, in certain high-performing individuals, particularly with certain sports, in a pattern that shows increase with activity, improvement with rest and flexion, that's what we should look for. Then you have the dull ache, lower back, gluteal posterior thigh, hamstring tightness, compensatory pelvic tilt. These are some of the clinical findings. But the one clinical finding that I find really useful is pain on hyperextension and on stalk test. Diagnosis is usually quite straightforward, and I'll just go through some of these lists that I have here in front of you, some of which are historic, and I would not recommend them. So plain X-rays, for example, is history. We should not rely on plain X-rays for identifying or diagnosing spondylolysis in the modern era. CT scan, thin slices, highly sensitive, specific. You can visualize the cortex and trabecular bone. You can look at location, size, pre-op planning, monitor healing. But the problem is radiation. And that is the reason why we should be thinking outside the box. CT has been considered a gold standard for a long time. But this is just showing the differences between X-ray and CT. And the fact that CT is very high radiation dose has to be explained to the patient. And hence, we have other options, such as MRI, particularly stir and wipe sequences. And if nothing else, then we have another option for more accurate diagnosis, which is the SPECT CT scan, which is unfortunately also high radiation. So CT scans have been replaced by MRI in terms of the use of T1 wipe sequences, which are volumetric interpolated breath hold examination. It's a type of sequence where you can pick up these spondylolysis fractures or the early stress incomplete fractures that you can also see them as complete fractures. In stir sequences as well as in these wipe sequences, we avoid radiation exposure. We can do it as often as we need to. They have a very high sensitivity, specificity, and accuracy. We have various classification systems that are based around the different findings of the MRI scan, which is pretty handy. We've also devised a classification in our unit where we can look at certain zones and we can identify where the fracture line is or where the fracture is likely to be. And based on that, we can have our future efforts to identifying and understanding this problem better. One of the new development is a bone MRI. A bone MRI is basically a software addition to our normal MRI. It's a more specific technological advance, and that shows the MRI pictures with as good a quality as a CT scan. So I think that's the thing for the future. If we have a particular diagnostic difficulty, SPECT CT scans are very good. They're very sensitive. They're low in specificity, but they show us where there's metabolic activities and the bone turnover. But like I said, they are radiationally very heavy, and you've got to use them very sparingly. Treatment options, I would say there are two main treatment options. Bracing is not something that I would recommend in any situation. Injections at best diagnostic. The one is rehabilitation and the other is surgical repair. Rehabilitation is really important to understand. It's a controlled process where you have to have a clear game plan, and you've got to have a physiotherapist or a sports therapist that actually knows what they're doing and have treated these patients before, and they know what the natural history is and what they are likely to get out of this. So I'll give you an example from the sports perspective, and I've had these discussions with a lot of physiotherapists that deal with the high-end sports persons, professional sportsmen, fast bowlers, and this is what they recommend in terms of, and this is a very crude game plan. It's a lot more complex than this. So to start with, the rehabilitation starts from the distal aspect moving up proximally. So the foot and ankle, which helps control the load transfers. And then you can move on to the pelvis and the core, which helps in improving the load transfers, countering balance, and increasing the strength bandwidth. The value of warm-up and cool down at each session cannot be undermined. The use of dry line activities is really, really important. It's really important to identify what offloads the posterior arch and then gradually reload it. And one of the things that can help in this process is what we call altered G running. And this is a type of a device that we can use for some of these sports persons, where we can control how much gravity their lower half of the body is in, so that we can control how much impact they have when they put their body through a motion of running. So this is called altered G running. And then we have the rest of the scaffold training and core drills, such as some of the ones that are seen here, and that we can build through this period of time as they start improving. And these are some of the other drills that we use from time to time, which are very good and useful. And they help in improving the core, and they help in specific activities and building up specific groups of muscles. During a rehabilitation, it's important to assess them clinically as well as with imaging from time to time. And as they get better, we can go through a more shorter run-up drill, leading on to a proper run-up, and then back to the play. Coming to the fixation techniques, it's important to identify who are the ones that have been through the whole rehabilitation process and have not been helped by it, or they still have breakdown of their spondylolysis from time to time, and they're missing time of sport, or kids who are not getting better because of lack of access to appropriate facilities. Surgical indications, timing, and planning return to their normal activities is important. Understanding the type of anchors, understanding the type of fixation we are using, and whether we use grafts or not is also important. So this example here is the more traditional gill technique, which involved getting the wires around the transverse process and so forth. It involved a lot of dissection of the muscles, and it's not something that I would recommend these days. This then led on to this kind of a smiley face technique that has been combined with this wiring technique by some. But again, that's a bit of a sloppy fit. And the reason I'm not very fond of it is because it damages some of the midline structures. And it's quite high profile implants, as you can see here. And you don't want your paraspinal muscles going over these implants in a high performing individual. These are my two go-to techniques. If it's an undisplaced fracture, then I'll go for a straightforward fixation of the pars with a single screw. Or if it's a displaced fracture or something with a gap and requires further grafting, or when there's a breakdown of the previous fixation, I'd go for a screw hook type of a configuration. These are some of the examples that I've seen from my practice. This is a fairly undisplaced fracture where we managed to find a good trajectory, identify the screw length. We managed to get a wire across, and got a screw up that, having drilled and tapped it, and we got a good solid fixation. This was a unilateral fracture, so we just left it with the one screw. We can actually do a lot of preoperative planning, and if you have a robot, you can use that robot to help you through this process. This is another example of a kid who had a 14-year-old who had this kind of a spondylolytic defect with very well corticated. The opposite side was a very high pedicle fracture that had healed, so we didn't have to do anything about that. So the one side we fixed with a hook screw system, and we grafted it, and we put some BMP as well. This is another example of a patient that had a well corticated defect with opposite side fracture that had healed well. Uh, not very uncommon to have this kind of combination, and this again we treated by this technique. This is a patient that had a very interesting one. A professional fast bowler, had been having multiple time off his cricketing career, and had a very low fracture, very high pedicle fracture here, and a mid fracture on the other side. So you can see this fracture which we fixed with a single screw, and the other side fracture we fixed with the screw hook system. And after 2.5 years of being on and off sport, he finally was fine enough to get back to playing at the highest level possible. There are some situations where you have a bilateral defect, well corticated, the discs start showing early signs of wear and spondylolisthesis, and rather than going through a repair phase, it may be worth just talking about a one-off operation and fuse that segment. It's something that we've got to individualize. You cannot have a one-size-fits-all, and you've got to be able to have some idea of what the patient's demands are, what their future is, and what they want out of their treatment. So based on the current research, we can create a risk-based matrix based on bone density, spinal shapes and profiles, and finite element studies and clinical studies are all in sync with what we've seen. Take-home messages: it's a commonest cause for time off sport for anyone who enjoys being out there, whether it's a child or a professional sports person. Rehabilitation is really important. It's got to be reviewed from time to time. Surgery is only on selected individuals, and it's common in high-risk individuals, and we should try and spot them early so that we can treat them. Thank you.
Thank you, Jwalant. Appaji here.
Hi.
Yeah. So a very comprehensive synopsis of how to go about diagnosing and treating a spondylolysis. So I mean, quite comprehensive for anybody to listen to this and understand. There are some doubts. One is about the follow-up investigations on a patient. How often do you investigate such a lysis patient on a conservative management?
If I'm doing an MRI scan, then it's only the access to MRI that's important. What I have in where I'm practicing is there are 2 MRI scanners where I have access to this wipe sequence. So I will insist that the patients have MRI scans on those. If I have a person who is on rehab and is asymptomatic, then I won't scan them. If I have a patient who is on rehab and the physio wants to go up to the next level and they are still asymptomatic, I will not scan them. But if they start becoming symptomatic, say at 3 months, 5 months, 6 months, irrespective of the time, I'll have a low threshold to getting them back in the scanner to see what that scan shows. So, and this is for rehab.
Yeah.
Obviously, for surgery, it's different.
Yeah. So you will prefer to do an MRI rather than a CT scan or a PET CT or a SPECT, right?
Absolutely.
So when you say that, when you say it is the MRI with the bone sequence, right?
Yes, MRI with the bone sequence. And the current way, the way things are, you don't have to put them through the whole MRI sequences of T1, T2, etc. We can tell the radiologist a specific problem, and we just say that this is what we want. They'll just do those sequences. The acquisition time is much shorter, and you get the answer.
Okay. So in MRI, if you are looking for in a regular MRI, if somebody doesn't have a bone sequence MRI, so what do you look for as a healing point?
So we need to think of back to the stress response. Is there a stress response? Is the stress response showing signs of decrease? So when the stress response improves, the edema reduces. So that you can see on the imaging. Is there a fracture? Sometimes you see a fracture with a reduction in the stress response or an incomplete fracture, reduction in the stress response. That's a good sign. So when you see an improvement, it's a regression of what you find when there's an evolution of the problem. So you can actually chart out to what extent it's getting worse or improving, both ways.
Okay. So if there's a non-union now, which has become cold, and MRI does not show a big gap, because MRI is not very sensitive to pick up less than, say, a 0.3 or 0.4 centimeter gap. So
Correct.
how to go about it?
So if you have a non-union that is symptomatic and your rehab is not working and you have a high performing individual, I would have a low threshold to operating.
Okay.
The problem with operating is there are lots of people involved in some of these high performing individuals. You have the team management, you have this, that, and the other. So you have to look at the best interest of the player. That's my first priority. Or of the child. It doesn't matter who it is that you're dealing with outside the clinic room, but you're dealing with the patient first. You've got to see what their future is. And if I feel that by fixing them at that time, I'll be able to get them to the next level of activity, I'd recommend early surgery. I've seen more cases that people have dragged on and said, oh, surgery can lead to X, Y, and Z complication, or that we'll try this. I would say no. If we've done the full rehab, if we are maxed out with that, the next step is going to be surgery if we can identify where the problem is.
So how long is this rehab program?
It's a line in the sand. If they're improving, they're improving. If they're not improving, we can say basically the rehab guys are very switched on. At least the ones that I work with. They will not drag it out, whereas some I've worked with in the past would drag it out and not want to pass it on to a surgeon. So if you work closely with these guys, they will come to you with the problem rather than you saying that, look, I can help you with this. So there's no number to it. And unfortunately, we cannot create that granularity, and hopefully we might in the future, but we are working on that.
Okay. Amit and Arjun are there. Amit Jhala, sir, do you want to ask any questions?
So anytime you will tell them that, if you don't operate, then you will have to change the profession, and it has happened anytime.
Yes. So what can happen is if someone has a spondylolysis that has been, I wouldn't say mismanaged, but either missed or not managed at the right way at the right time and leads to a gap, and they are likely that they won't make it to the higher level that they want to, then they've got to take a call. I won't take names because it's not fair to, but I've had one chap who was a younger brother of an international player who had a spondylolysis, and I had to tell him that, look, whatever happens, you're not going to be able to play at that level. So we've got to think of other options. And if that is the case, then all we have to do is do the best for them so that they can still not have any problems in the future. It shouldn't be that just because they can't make it to the next level in terms of sports, you don't treat them. You can still treat them operatively. You can still give them the benefit of the doubt and get the parts to repair.
So, sir, non-radiological criteria that you have for fusion instead of other than pars repair?
Non-radiological criteria, clinical.
Like one of the criteria is the design. Yes.
No, sorry, just say that again. What's your question?
So one of the criteria that we would prefer to do fusion over a pars repair is the condition of the disc. So that would be a radiological criteria. Any non-radiological criteria that you will have in your mind when you plan a repair versus a fusion?
So if it's a heavier patient, if it's a larger person that we feel that the repair is not going to be able to be withstood with the patient's forces, or if they are in a sport where stability is more important. So in some sports, it's better that you get that fusion done with so that they can get back to the highest level rather than worry about repair, especially at the L5S1 level. That's when I would push for, like I've done that in a rugby player many years ago, where I went for a fusion option rather than a repair, and I didn't regret it because it's a very, very aggressive sport, and I could get him back, and I was quite confident that I wouldn't have to convert that to a fusion.
So once you opt for a fusion in a young child or maybe in a sports person, the life of a sports person is very, very small, maybe 8, 10 years or 15 years maximum that they are active. And if you opt for the fusion, would you allow them the same activity as it was before, or you will restrict them at certain point because it's for their whole life?
Yeah, I mean, the thing with fusion or whether repair, either way, once I have achieved my surgical goal, I'll get them back to doing what they want to do. The aim of all our efforts is to get people back doing things at the level rather than holding them back. If I'm to hold them back, then why bother doing all this? It's a question of when I get them back to playing that level of sports, not whether I do it or not. So I'll definitely let them go back. And I think in some ways, once it's fused and the rest of the spine and the hips and everything else is has the appropriate compensatory mechanisms, then sky is the limit. Then they can get back to doing whatever they want to. But I would not want to fuse a high-level sports person early unless that's the best option for them, and it's quite rare. I'd rather go for a repair option.
And as far as the threshold for investigation is concerned, for an active sports person who's a professional fast bowler, would you investigate that bowler immediately with all the available investigations, or you will stage them? And what is your prototype or your way of doing it?
So in terms of investigating, usually MRI is good enough. And in fact, there was a paper that came out recently which showed that regular MRI for all the fast bowlers as a screening tool is good enough to pick up these fast bowlers, particularly fast bowlers, with a stress response. So you want to pick up those guys with a stress response and then treat them. Once they become clinical, then it's a bit different. So you want to pick them up sooner rather than later. So at least with some of the cricketing bodies here in England, there's a screening way of doing an MRI at the end and the beginning of a season, and that's something that I would recommend to a lot of the other sporting bodies, because it's a way that you can identify a problem and pin it down before it becomes a clinical problem.
So coming back to the fusion, Jwalant, what are the long-term studies after the fusion in the sports person that they have got the adjacent segment or any other issues, or they have to leave the sports? Anything on the long-term studies?
No, I haven't come across any long-term studies, and a lot of the sports-related work is, so for example, microdisc, there are long-term studies in ice hockey players and in some other sports, where what they say is that if you put someone through the usual conservative trial and even a high-level sports person is not improving, you do a microdiscectomy, and the long-term outcome is the same in about 7-8 months. They're back to sport in about under 9 months. We can say that. Long-term, I don't think there are any such long-term studies, because this is a very unique group of individuals. And whether it's for scoliosis, return to activities in sports, or it is in with spondylolysis or spondylolisthesis return to activities. There's a lot of ad hoc, common sense, individualized thinking involved, and I don't think we can rely so much on literature. Not yet, at least.
Okay. So the other thing will be, if you are looking at repair. So you showed the hook screw technique and the bucks repair. So do you use minimally invasive techniques, or do you, I mean, like a navigation or a robot, or you just use image guidance and then do it?
So if it is, so basically, I would recommend a minimally invasive approach if it is possible. If it is just a single screw, then definitely a stab incision and you can do everything to that screw. If you have a robot, fine. If you don't have a robot, you can do it MIS, just with normal either nav or with II. It doesn't matter. As long as you can be sure and accurately place screw exactly where you want it to be. If it's the screw hook system and you want to graft it and you have a big defect, I would have a slightly different threshold. I would open up that area, strip the muscles very carefully so I don't damage the tendons too much. I mean the tendinous attachment of the muscles. Even if it means going through the muscle belly and creating a bit of scarring there, that's fine. Creating a little trough, decorticating that area, putting autografts there from the same patient, and we have a device through which you can get small trifines from the crest. So you don't really need to go with a osteotome and take huge chunks out. You can take a lot of multiple small trifines and you can supplement that with BMP. But what's most important is to curate it, drill it if required, and get some nice healing, nice bleeding bone. And that's what's going to. So back to first principles. You can't compromise on that.
It'll be a midline dissection, not a Wilsey type of an approach.
If it's bilateral, then I will see, but you don't have. It doesn't have to be. It doesn't have to be Wilsey. You can do a midline.
How early will these patients be allowed to resume, say, even normal activity rather than sports, and then how early for sports?
Okay, so good question. So I would say my first aim is to get them to heal, and many of these sports guys, the sports team themselves will be looking at their vitamin D, calcium levels, and all those. So I don't have to worry about that. What I'd say is 2 weeks of nothing, just relax, chill out at home, walk around, don't do anything major. After about 6 weeks, you can start a bit of groundwork. You can start doing a bit of low impact. Even with the altered G between 6 weeks and 3 months, you can increase the altered G from, say, 90% up to about 30-40%. So you're increasing the load on your back over a 3-month period. And between 3 and 6 months, you should be able to go through all the rest of the core and other activities. And I would say by 6 months, I would usually want to see them back on the field.
6 months is the ballpark figure.
Usually, yeah, usually.
Okay. And if they are returning to activity, literature or your experience, how many of them have come back with, say, a failure or a progression into a lysthesis?
No, I haven't seen anyone come back with a lysthesis because these are, that's quite rare. Failure, yeah. Sometimes what you can do is you get a check X-ray done and they're asymptomatic, but the screw is broken if it was undisplaced to start with, and the fracture is resolved. But again, if they are performing at a high level and there's no problem, I would not do anything about it. If they're symptomatic, then I would treat it. But I haven't seen anyone coming back with lysthesis or a failure in that context that you're mentioning.
Yeah. Arjun, are you there?
Yes. So it was a great
any
talk.
questions too? Yeah,
great talk. Thank you very much, Dr. Jwalant. I had a question. In a sort of in your approach towards a unilateral lysis versus a bilateral lysis with back pain, how differently you'll manage them in terms of your protocols, and also if you can elaborate on the role of injections.
Injections are only if you want to know where it's coming from. If there are multiple other pain generators and you're not sure, then do it. Otherwise, it's a waste of time. Very likely, there's a saying that I heard many years ago. If you hear hoofbeats, think of horses before zebras. So that's something to keep in mind, unless you're in Zimbabwe where you are likely to have zebras more than horses. That's another matter. But in terms of injections, I'm not going to do that too often. What's your second question? Unilateral versus bilateral. Yeah. I would say it's the same thing in terms of whether you do unilateral or bilateral, the protocol is the same, rehab wise. Not much different.
Thank you.
Okay. So, Amit sir, you have any questions?
So we have questions on our
Yeah,
YouTube
from
live.
from the audience. Yeah.
Yes. So we have a question from Dr. Sharvin Sheth from Ahmedabad. So he's asking that what if a patient is a low activity who is not in sports and is complaining of chronic pain with PARS? So how would you manage these kinds of patients who are non-sport persons?
So first principles, exactly the same as for anyone else. Start up with rehab, whatever rehab you can get. Ask them what their requirements from life are, how bad, how much this is affecting them. And if it is really bothersome, then I would not fuse them. I would repair it as long as the disc is intact, and then get them back to their normal activities. Just repairing it is not a problem, but I would definitely want to go through the usual steps of rehab. If it is working with the rehab, great. If it's not, the next step is to look at surgical options. If it's undisplaced and a single screw, if it's displaced, then you can have any of the other constructs, screw hook or smiley face or whatever you'd like, whatever you are comfortable with, just to get that to heal up. But if you want to do that, make sure that you create the defect, exaggerate it, fill it up with bone grafts and BMP and, the first principles. So exactly the same as anyone else.
So, my follow-up question. So, how much of degeneration is acceptable for a repair?
No, there's no such number. Some
Value.
people, purists would say, if there's any sign of degeneration, you should not be offering the repair. I would say that the reason you're getting the degeneration is because there's a anatomical abnormality in the facets being overloaded, and hence the discs are overloaded. So by repairing, you are influencing the natural history of that degeneration. So I would have a low threshold in a teen to repair rather than fuse. I'd have a low threshold.
Okay. The next follow-up question on that: a normal disc, but there's a spondy.
A lot of these spondies that people say are actually developmental. We've got to see it carefully with our own eyes, not just read the report. A lot of the reports I see in kids, particularly teens, they say L5S1 grade 1 spondylolisthesis, and you look at the scans and it's more of a developmental finding.
Yeah.
I would not call that spondylolisthesis. And I would tell the patients that this is not spondylolisthesis, so don't worry about it. And I think it may be a question of playing with words and not scaring the patients.
Last question from me. So you do a repair and you are packing graft in that area where the exiting route is going to go out. So have you seen radiculopathy?
I haven't, but it is possible. So I would definitely say you've got to be really careful that you pack grafts in such a way that you pack it, not just layer it there. And that's why it's important to drill so that you create that little rough surface where you pack it. The second thing is, if you put in bone morphogenetic protein, don't put too much of it, because if you put too much of it, some of it can leak around the nerve roots and it can cause radiculitis. So I would definitely say all these things you've got to keep in mind. And surgical technique and craftsmanship and carpentry is super important.
Thank you, Jwalant. Hriday, any other
Yeah,
questions?
So one more question from Dr. Michael Anthony Louis Rex from Dubai. He has sent his regards, and he has a question that do you do CT scans to check for healing in parts repairs?
So if I've repaired them, then I have to use some other imaging other than MRI, because MRI is not that sensitive unless the radiologists can do some kind of image unloading MRI or the Mars type scans. But if usually it has to be a CT scan, in which case what I would do is I would go back to the radiologist and say, I need to know that whether this has healed. So they'll do limited cut CTs of that area and they'll reformat it just to keep the doses down. So yeah, it is possible. Yeah, we would definitely do it. But have a clear conversation with the radiologists.
So yeah, so that's all about the questions that we had. So I think this was a perfect time to have a topic on spondylolysis. There's a World Cup going on. There's India playing today, Australia. There's rain, of course, but the perfect time to have a talk on spondylolysis this time around. So thank you so much, Dr. Jwalant Mehta. It was an excellent talk. Probably we have had the maximum discussion in this year's webinar series that's in this topic. So thank you so much for such an interesting talk, and thank you all the faculties, and thank you to all the participants who have been asking active questions. So before we end, I'd like to share a couple of updates about our next webinar. So our next webinar is on neuroaxial anomalies in pediatrics. He is a neurosurgeon in Germany, and that will be on the 13th of November. That is next month. So stay tuned for this very interesting session. So I think all our orthopedic and neurosurgery colleagues will be really interested in this. So there's one more thing. We all know there's the first PSA and AIMS Rishikesh combined annual conference coming up on the 15th and 16th of this November. If you have not yet registered, you should not miss this. If you are interested in all the pediatric deformities, pediatric spine, because the theme of the Congress is pediatric spine deformity, and all the Pediatric Spine Academy India faculties would be there, and you can meet them in person. There are workshops there. There will be our 2-star faculties, Professor Raj Shekharan and Professor Bong Keith will be there in Rishikesh, and it's the perfect time of the year to be in Rishikesh. Next is there are 3 workshops planned. One is on deformity correction by Dr. V Menon, the Midas workshop, and the robotic spine surgery workshop. So there's a lot to offer in the Congress coming next month. And before that, we have our session on neuroaxial anomalies. So see you all in the next session. Thank you so much, Dr. Jwalant. Thank you to all the PSA committee members to be here. Thank you.
Thanks, Jwalant, for joining us. It's
Thank
a
you,
pleasure
everyone.
always.
Thank you, Jwalant. Thank you very much.
Thank you for this opportunity. Really good to be with you guys, as always.
Yeah. See you soon somewhere.
See you. Bye.